Medication Administration, Part 3. This is Martha Olson from Iowa Lakes Community College. As we look at error-prone abbreviations, we see that they should be avoided so that we don't make medication errors. QOD is supposed to mean every other day, but it can be taken for other things. SC can be subcutaneous. SQ can also be subcutaneous. SSRI is the abbreviation for sliding scale regular insulin, but it's also a drug class that we see in mental health, selective serotonin reuptake inhibitors. So the Institute of Safe Medicine recommends no abbreviations being used for that reason. We always want to double check medications because of safety. Some medications that should be double checked, any pediatric dose, because we usually base it off of their weight. Insulins are supposed to be double checked. Your anticoagulants that cause extended bleeding time, such as Coumadin, heparin, Lovenox, need to be double checked. Any of your chemotherapy agents, IV potassium, which is never given IV push. Remember, it's always diluted in a bag or diluted somehow to be administered. Anything you're unsure of, the double check with another nurse. Can you check my math? And have them do it separate away from you so that you are not influencing their answer by saying, did you get 2 milligrams for that one? When we question an order for a variety of reasons, if we can't read, back in the old days when doctors wrote in charts, if we couldn't read their handwriting, if something just doesn't seem right, because whenever we try to guess or think, well, that looks like it'd be about 2 milligrams, that is gross negligence, and that is not something we want to get in the habit of doing because it can only lead to trouble. Medication orders, there's many different types. A standing order is one that is always there. The hospital has standing orders that say people with a headache can get a Tylenol. Now with standing orders you have to be very careful because there are times when the standing order is not appropriate and the nurse needs to know that. Components of any medication order, you always have to have the name of the med, the dose, how much to give, the route. Is it oral? Is it rectal? Is it inhalation? How often? And then the physician needs to either physically or electronically sign that. Our standing orders then are usually for an indefinite period of time. They remain in effect until either a new order is written or one is canceled out. We would not want to give aspirin for a temp above 101 if it's a new surgical and they could potentially bleed or hemorrhage, because we know aspirin is also an anticoagulant. The order is canceled automatically by agency policy. So typically your standing orders are things that are very basic. If somebody has an upset stomach, maybe they can get a Tums. Headache, they can have a Tylenol. We have to always stop and think about what kind of standing orders would be appropriate. As I said, aspirin 325 milligrams PO every 4 hours is a standing order for some facilities. In the hospital, not so much, because aspirin has the 3 different properties, with the anticoagulant being one. Would it be appropriate to give a new surgical client an aspirin for a fever? No, that would be a patient that you would want to do a good assessment on, call the surgeon and explain that they are running a fever, and they will possibly order blood cultures and then an antibiotic. Would it be appropriate to give a standing order for a Fleet's enema to a client that has just returned from having a hemorrhoidectomy? No. Fleet's enema for constipation would not be appropriate in that case. So again, you can have standing orders, but they may not be appropriate, and you have to think about before you give them. PRN orders are as needed. So if the patient has a pain pill ordered, they might have it Q4 hours PRN, and that means when they have pain and they ask for it, you can give them that as long as it's not closer together than every 4 hours. We also need to watch for any scheduled pain medications. Perhaps they get an oxycodone every 6 hours, and it's only been 3-4 hours and they're asking for a pain pill. Are they going to get another scheduled medication very close that could cause some problems? A single one-time order is just give it this once and that's it, and perhaps it's just a Demerol 100 milligrams IM or intramuscular every 4 hours for 12 hours and then discontinue. So you have just a one time, you can give it this once, but then don't do it again. Stat means get it done immediately. I need it done right now. Patient that's going to surgery and they need something done stat, they need it done immediately. A now order, you can give it quickly. They want it done within 90 minutes. Telephone orders, we should only get telephone orders from surgeons, from doctors, physicians, when it's very urgent. They have to come in and co-sign those with us within 24 hours. And if you call a physician in the middle of the night and he says, go ahead and give him a Demerol 50 milligram IM at this time, you would want to say, okay, doctor, thank you for the order. I'm going to read back now that you want Demerol 50 milligrams IM given at this time to Mr. Jones. So the read back is kind of a way of double checking that you heard and wrote that order down right, because there is a very narrow margin of safety with many medications, and we would not want those orders to go on if they were not correct. On the medication administration record, or MARS, how they're often called, they are initiated by the physician, and it's called CPOM. It's Computerized Patient Order Management. And that's where the doctor sits at a computer and decides what meds and what treatments and lab values he wants done, and he orders them on the computer. When we look at our MARS, we have many different types depending on where you work and the system that they have, but they all work about the same. When we look at the MAR, then we know that the physician starts on the computer by putting the orders in. The pharmacy will verify the order. It will then come back to the floor where it will be acknowledged by the nursing staff, either a resource nurse, supervisor, or the floor nurse. And once you acknowledge it, you're saying, I looked at the physician's order, I see the pharmacist set it up correctly, and I'm going to say, yes, everybody so far has done this correctly. So when we double check, that is kind of giving our signature to it, and we are liable then for that order. We take the computer into the room then, scan the client's wristbands, scan the medication, and then we verify with our triple check that we have done our 6 rights and we are administering the right medication. An older way was to have the physician ordered on a sheet of paper that had like triple copies, and one copy would get pulled off and sent to the pharmacy, and if you were lucky you could read the handwriting and what it said on there. Today they're generally computer generated, and it's a much safer way of getting orders transcribed without worrying about somebody's handwriting being misread. With a physician's order, any patient that goes to surgery, we remember that all orders are null and void. When they come back from surgery, then everything has to be reordered by either the surgeon or the family physician. Our medication delivery has changed a lot in the years that I've been a nurse. I'm in the old days of when we used to have the med cart and we'd push it up and down the hall, passing our medications in the evening with the med cart sitting outside of the door. You will still see those in some of the long-term care facilities. Most every hospital that I'm affiliated with, we have now either a Pyxis, or in Spencer they have what's called an OmniCell. They're a little bit different, but they're computerized machines that you have to go in and sign in, put your fingerprint on there so that they know it's really you, and get the medications out that way. Our steps for a Pyxis send, we log in with our fingerprint or password, we select remove medications, touch the patient's name that comes up on the screen that we want to give the meds to, select either the medication name of what we're giving, or there is a quicker way that says remove by time, and if it's 9 o'clock in the morning, all the medications that are scheduled for 9 a.m. will show up on the screen. We do our first triple check when we take that medication from the Pyxis drawer, and then be sure when you leave that Pyxis that you log out so that somebody doesn't come behind you and take medications out under your name, because you're liable for that login at that time. The benefits of the unit dose meds, they really do not increase the cost. They're a lot safer. We can scan them with stock dose. We were doing a lot of wasting, and so when we look at unit dose meds, we see that it is very beneficial. Our other medication delivery system is the cart Make sure that if you have the cart and you're rolling it up and down between residents' rooms, that you're locking it in between. Many of the carts have medications and water and juice and things on top, as well as the Mars, and so we aren't seeing those used a lot, except, like I said, in long-term care. Some of the special circumstances, meds need to be given on an empty stomach. Then we usually give them 1 hour before or 2 hours after a meal. If it has to be given on a full stomach, make sure that either they have a meal or at least you give them some crackers or toast, something to have in their stomach, because many of the meds are very GI irritating. And if you give a potassium, an iron pill, those will cause your patient to vomit if you give on an empty stomach. If your patient is NPO for x-rays, we want to make sure that we are holding meds and then give the meds late when they come back from having their tests done. Meds will interfere with many of the x-rays, and so you might want to just clear that with the doctor when those types of x-rays are ordered. Drug interactions, the Potter and Perry talks about synergism and antagonism. Synergistic is when you get a greater response from two things. They work together. It gives you a stronger effect, or what we call potentiation. It's kind of like two people that get along and they collaborate and their energy is very well spent together. We give narcotics with Tylenol because we know that the Tylenol makes that narcotic work better. We also do this with many of the blood pressure meds because a lower dose of two different types of blood pressure med classifications works better to decrease that blood pressure. So synergism is two meds working together to have a good effect. Antagonism, that's when somebody antagonizes or irritates you. It's when one med or drug diminishes the effect of others, and it's usually a weak effect, but it's things like I take a Tums or an antacid with a medication, and the Tums kind of inhibits the absorption of that medication, so it doesn't work as well. Other food and drug interactions that we know, cigarettes can have a negative effect on some meds, as can caffeine. With any antihistamine, you definitely need to avoid alcohol. Alcohol is not really recommended for any of the medications. As you read the drug book, you'll see that listed many, many times. Diuretics interact with electrolytes, specifically your potassium and sodium, and they can diminish those electrolyte levels within the body. Vasodilators to lower blood pressure and antihypertensives have to do with sodium. So there are food and drug interactions we need to be aware of. A big one is your Coumadin, your anticoagulants that make longer to make a blood clot. We know that foods that are very rich in vitamin K inhibit that. So if I eat a lot of spinach and asparagus and good green vegetables out of the garden, my Coumadin is not going to work nearly as well because of the effect from that potassium. Bronchodilators with caffeine cause a lot of increase in heart rate and jittery and shaky effects to the patient. And then your aspirin and corticosteroids definitely need to avoid alcohol. Some of the other interactions we see, heart meds and our lipid lowering, our statin medications, interact with citrus juices such as grapefruit juice or grapefruit. Should not be taking any of your statin medications with grapefruit juice. Birth control pills interfere with some of your B vitamins. We know some of the antibiotics interfere with birth control pills. That is a huge part of teaching. And when you have a young person come in that's on birth control pills and they get an order for an antibiotic, you need to make sure that they understand that and get a backup plan for the rest of the time that they're on those antibiotics. I know a couple of girls that had wisdom teeth out, were put on antibiotics, and they wound up getting pregnant. And so there is where good teaching is very, very important. Anticonvulsants speed up the destruction of vitamin D. In your notes behind that, you're going to put vitamin D keeps your bones strong. People that take anticonvulsants for years have higher rates of osteoporosis as a result of the breakdown of that vitamin D. Tetracycline and calcium bind together, tetracycline in milk. So your tetracycline will not work because the milk kind of binds it and keeps it from being effective. So there are a lot of interactions that we have to think about. We will continue on in part 4, looking at some of those medication interactions and evaluation of drug effects. Thank you.